ตามแผนทันตสุขภาพสำหรับผู้สูงอายุประเทศไทยพุทธศักราช 2558 ถึง 2565 ซึ่งคณะรัฐมนตรีได้อนุมัติเมื่อวันที่ 6 มกราคม พุทธศักราช 2558 เพื่อช่วยแก้ปัญหาสุขภาพช่องปากผู้สูงอายุกว่า 10 ล้านคนทั่วประเทศผลจากการเกิดนวัตกรรมต่างๆเหล่านี้นับเป็นการพัฒนาการผลิตด้านทันตกรรมของไทยให้ทัดเทียมอารยประเทศเกิดการผลิตขึ้นเองภายในประเทศไทยทำให้สามารถพึ่งพาตนเองได้ตามพระราชปณิธานและบรรลุพระปฐมบรมราชโองการที่ว่าเราจะครองแผ่นดินโดยธรรมเพื่อประโยชน์สุขแห่งมหาชนชาวสยามอย่างสมบูรณ์
ปากแห้งแล้วก็คอข้างในเนี่ยแห้งมากทำให้การทานอาหารเนี่ยลำบาก
พี่สาวเนี่ยเป็นโรคซึมเศร้าแล้วก็มีปัญหาเรื่องหัวใจแล้วก็แกจะมีปัญหาในการขบเคี้ยวอาหารการไม่เท่ากัน
คือเลือดอะค่ะมันก็ออกมาตามสายอาหารที่เขาใส่เข้าไปเพราะว่าพอเขาดิ้นนะคะมันก็จะไปทิ่มในลำไส้แล้วก็ทำให้เกิดเป็นแผลข้างใน
เรื่องก็นึกในใจว่าท่านเนี่ยทำทุกสิ่งทุกอย่างเพื่อประชาชนเลยนั่นก็ไม่คิดเลยว่าแม้กระทั่งยาท่านก็ยังจะช่วยประชาชน
จากการที่เคยกินได้น้อยก็จะทำให้อยากกินอาหารได้เพิ่มขึ้นมากขึ้นแล้วก็จะเน้นตัวพัฒนาเจลลี่ตัวนี้
นอกจากแค่เรื่องอาหารที่สามารถให้ทางปากได้เนี่ยคืออาการทางจิตใจของคนป่วยที่ดีขึ้นนะคะทำให้ร่างกายเขาหายป่วยเร็วขึ้นจริง
ๆซาบซึ้งมากเลยคือท่านรู้สึกถึงความเจ็บปวดของคนอื่นท่านเห็นใจท่านทำได้ท่านทำให้ทันที
ขอท่านได้โปรดใช้อะไรข้าพเจ้าบ้างข้าพเจ้ายินดีรับใช้จนสุดชีวิตเลย
ซาบซึ้งในพระมหากรุณาธิคุณหาที่สุดไม่ได้
คนป่วยทุกคนถ้าได้เจออาหารนี้จะช่วยเขาได้มากเลย
ขอให้ท่านอย่าได้ทรงกังวลประชาชนทุกคนจะรักท่านตลอดไปค่ะ
Good morning. Welcome to the third online webinar of King Rama IX Dental Implant Development Center Study Club. Today we have a very honored speaker from United States, Professor Douglas Sinn. He is specialized in facial cosmetic surgery, craniomaxillofacial surgery, jaw surgery, management of disorder of temporomandibular joint, dental implant and dental alveolar surgery. He is a clinical professor and past chairman of the division of the oral and maxillofacial surgery at the University of Texas Southwestern Medical Center at Dallas. And he was on the UT faculty from 1974 for 30 years until 2004. He joined the faculty after completion of his residency at the University of Texas Parkland Memorial Hospital and its affiliate. Prior to then, he received his bachelor degree at the University of Iowa and his dental degree from the Creighton University in Omaha, Nebraska. After joining the faculty at UT Southwestern Parkland Memorial Hospital, he was actively involved in the direction of the resident education and the management of the patient at Parkland Hospital. He was named director of the residency program in 1978 and was promoted to the associate professor in 1980. And since then, in 1984, he was named as the chairman of the residency program, which coincides with his promotion to the full professor. Now, he was an active private practice in facial and oral surgery based in Mansell, Texas. He has attending staff privilege at the Mansell Methodist Hospital, Medical Center City, Dallas, Baylor University Medical Center, and Children's Medical Center of Dallas. Professor Sinn is board certified and serves as a president of the American Board of Oral and Maxillofacial Surgery. He also serves as the chairman of the Oral and Maxillofacial Foundations. He is well known both national and internationally in specialty of the oral and maxillofacial surgery, and he has written many articles, books, and book chapters. He has been active as both speaker and consultation in the oral and maxillofacial surgery. He currently maintains an active role in teaching on part-time basis within the UT Southwestern Medical Center and affiliate hospital. I would like to all of you to welcome Professor Douglas Sinn, and his topic today is related to the facial rehabilitation with craniofacial implant. Please welcome Professor Sinn.
Okay. Hello. I just like to tell everybody hello. I'd like to thank you both for inviting me to visit with you this evening. And we're going to look forward to some interesting patients and their management, beginning with facial rehabilitation and craniofacial implants, which is where our main focus is. So I'm going to go over here and give a little bit of historical background. And you can see here that back in the 50s and up until 1975, we had made some major steps forward and went on until that middle 80s. And when the Brandmark folks became very influenced on this problem, it was some type of a improvement for us with Brandmark, because we had a lot of different new things to do, and we were able to do them with the treatments that we had in our so let's talk a little bit about some of the indications. We're talking about primarily a group of trauma patients, Magellan disease, congenital malformations, and bone conduction hearing aids. If you look here, you can see some contraindications, and some of the patients that have those contraindications, especially immune compromised patients. We plan an adjunctive chemotherapy approach, and preliminary evidence of tumor recurrence is usually an indication that we cannot treat the patient, either the primary or the secondary. Insufficient osseous height and width, of course, is something that we can have some type of insight on in our work. So our preoperative planning is fairly extensive. It includes a comprehensive evaluation of treatment and planning that consults the patient both at the maxilla and mandible prosthetically, and once we have gotten that to that point, we can develop surgical guides in order to make a decision as to how we're going to change or add information to the soft and hard tissues. So we have some films that taught us that. There are some traditional films that I didn't bring those today, but we have computerized tomography also. And so we have a lot of operative things that help us move forward. The surgical technique that is used as an incisional flap approach. We mark where we would like to place the implant. We do a small pilot drill. We do an implant drill, and then we put the implant into the bone. And once we've done that, the abutment is covered usually and saved for it to allow some time for healing, anywhere from 3 to 6 months. And then soft tissue management, of course, may need to be modified at the end of that, and we can move forward with soft tissue changes and then to their closure. Now, once we've gotten to that point, we have some things that are a problem. And the problem starts with infections. And so we deal with that by giving all of our patients pre-surgical antibiotics, and we maintain post-surgical antibiotics for usually up to 10, 12 days. We also have to be aware of patients that have poor bone, and the poor bone is usually related to some type of destructive or bone disease, and that would be a contraindication. Radiation therapy, if it has been treated recently with that, or even titanium allergies, both of those are contraindications for our treatment and would not allow us to move forward. So the advantages that we have in our hands as we move forward are the advancements of the donor site and making sure that we have something that is in the proper position. We then can do some reconstruction if necessary, either with hard or soft tissue. And we can do transcutaneous healing if we have a single stage operation. We can also use the implant placement technique usually at the same date if there is satisfactory hard and soft tissues. And of course, the incidence of complications are very low if we choose and follow the records and the recommendations, that I've just have reviewed with you at this time. So let me just show you a couple of the fancy tools we have. If you see here, I think I can point to these with my nail. I can't really point to them, but yeah, I got them in there. You can see this little arrow. But these are just techniques to place implants that are very popular in the United States, and I'm sure in your country too, where we prepare the hard tissues, and we can use some drills, that some are which done by hand and others are done with a motorized system, as you can see in the upper left-hand part. And then once we've established that, we're going to put an implant into the osseous opening that we've created. And once we have that, then we can move forward to placing an implant into the metallic positioning, and then we can do an implant, what we call an implant torque. And that's what this photograph is showing, the torquing, and it's approximately 15 to 20 movements to make a proper outcome with this hard tissue. Once that is done, then we're able to review this with osseous trauma and also soft tissue management and the placement of reconstruction and management of these problems in these cases also, because not every patient is an ideal tooth extraction with an implant placement. So we're talking now a little bit about some trauma, because I'm sure that you're like we are here. We have a fair amount of trauma, and it requires special treatment, usually with irrigation and low speeding, a low speed preparation to correct the osseous issues, and then associated soft tissues also have to be addressed when we're talking about considering the possibility of any kind of implant initially or later, because in both cases we may have a situation where we may not be able to do it in one stage. So we talk about this initially as a two-stage procedure, when in fact we can occasionally do it in a single stage, but usually primary stability is better if we allow time for the bone to heal or to respond to some type of drill or reconstruction. Single stage, after that, we can load those kind of treatments or implants in 6 to 12 weeks in most cases. A good evaluation with a radiograph as well as clinical evaluation will allow you to make a decision as to whether or not you can place an implant earlier than normal and have a shorter rehabilitation time in your hands, which is, of course, if the patient's like that. But if you race it sometimes and do it too quickly, you'll end up losing the implant and having to do it a second time, which just delays things significantly. So the next thing of concern is the quality of the bone. And you need to have bone that's adequately thick enough and strong enough to accept an implant that is, 4, 5, or 6, 7 millimeters in dimension. And if we don't have that much, the chances of success are very low. And we can usually place 2 to 3 implants effectively if we plan it properly. And then we just sometimes can put 3 or 4 implants in the maxilla, sometimes on one side, sometimes on both sides, and sometimes we can add some to the mandible simultaneously. So here's a patient that we had a situation. You can see here a young lady had some significant problems here up in the area of her ears, and lost some significant bone and soft tissue. And wait a second, that's and you can see here the way that it was managed is some guided implant positioning. Guided implant positioning. This is up in the ear area where we've had some both soft and hard tissue loss. A graft has been placed, as you can see on the right-hand side here. And then in addition to placing a graft, we put a temporary plastic guide. And then, as you can see here, right here, we have placed implants where my arrow is that goes right through the guide, and it also goes into the bone of the patient. And that's put in that position so that we can take out we can cut away the soft tissue or the artificial tissue, And once we do that, we have a scenario like you see here over on this right-hand side where we placed our implants and we're getting ready for some type of a reconstruction in order to place an implant in that area. So this is near the ear also. You can see here, patient has 3 implants that have been placed in the defect around the ear. And this, of course, is going to hold the hard and the soft tissue when the reconstruction takes place. So this is what it looks like down the road after the soft tissue is healed. And I think you can see pretty well what these implants look like. You can see very clearly here that this is the ear and the soft tissue. And we have on the other side, we have some injury too that we were able to do simultaneously with this patient. Here's the post-operative outcome. Basically, you can't see that it's even been operated. It's a nice outcome, looks good. Of course, it's a young patient, which heals good. And that's, of course, part of the problem. And here's the patient down the road, covered up a little bit with hair in the front and the back. But you can see on this patient's right side that basically this hard and soft tissue reconstruction is, for the most part, very good. This just shows another view of the implants. And this is the post-op outcome you can see here, doing very well without problems. Now here's a lady that unfortunately lost a large portion of her ear, and it was related to an infection. It was reconstructed after the infection was managed, and I'm going to show you in the next view what the treatment plan was going to look like. You can see here both a soft tissue and an implant plan was going to move forward with treatment of this patient. And this is what it looked like in real life. You can see here the implants I'm pointing to now, right up here. And it looks like there's 3 eyes there, but there are really 3 implants. And this is the opening at the bottom of the ear. And then this is after we've attached an artificial ear over the top of that onto these implants. You can see the patient's hair has been pulled back, but the anatomy is quite good and without any significant complications. This is the patient post-op, and cut off a little bit on the left side because of that photograph of us, but you can agree that the outcome was pretty good. Now here's another patient. This patient had some very significant skin issues, and mostly irritated by when he was out in the sun and everything, and he had really poor tissue around his whole face and around his ears. And here you can see we're focused here on an ear again. You can see the patient had need for placement of implants, which are placed up here on the right-hand side. And you can see the prep of where the implants were placed. Here's one implant that is in place. But, you know, this is just something that you don't expect to see very often, but you do see it. Okay, so this is just the finished product. This is patient from the front, and this is the the right side, which was operated, and the left side is covered up a little bit by the pictures of the slideshow, so we can't really move that over so that you can see it. So let's talk a little bit about orbital implants. I think that's an important part also. And our implants have to be at least 5 millimeters in dimension in length. We'd like to have the lateral rim to be 3 to 4 with the implants. We can place those implants and have pretty good predictability from the standpoint of long-term benefit. And if there's anything that we can do for the recipient side, we can probably get a better outcome if it's done correctly. There are some increased failure rates in patients that have thin skin and hard, tough bone, and you're trying to place a big implant, or at least a fittable implant. And you can get yourself in some pretty good trouble here. We have a little cutoff again here. I guess I can't do that either. Yeah, wait a second. I'm just going to move that over a little bit. You can see on this patient, he had lost his left eye. And if you look at the top here, this was the defect. On the bottom, the patient has 3 what we call micro implants. They're extra small. They're placed in the osseous area so that they're stable, but you have to have at least 2 and preferred 3 in order to have proper stability. Here's just a close-up. The implants are in place, and you can see a successful placement of an eye that is false, of course, on the patient's left side, and it is connected with not only the soft tissue but to the implants that were placed in order to stabilize it. Here's another one similar. This is the face, the faith, not real, so to speak, eye bristles and soft tissue in order to place that in this patient's defect of the left upper and lower eyelid. And you can see it's replacing hard tissue, soft tissue, and a fairly effective non-mobile orbital reconstruction. Here's the patient post-op. You can see she's got some glasses on. You can also see what it looks like when she takes her artificial prosthesis out. You can expect, you gotta admit it looks really good, and the patient has had it very successful. Another technique that we'd like to talk about briefly is nasal maxillary implants. Something that we don't do as frequently, but osseous structures can be very thin and very difficult. And we have to place implants toward the nasal cavity for the most part to get proper bone and have good stability. And it's possible, it's not impossible, it's difficult, but once it's done and it's done right, you can end up with a really good outcome. Here's a patient also with a lost upper left eye. You can see 4 implants in place on the lateral portion of the maxillary defect. And you can see in the right photograph that the patient has replaced his missing eye with an artificial implant, an artificial upper eyelid, and of course a lower eyelid is also artificial. And for the most part, you can't change, you can't really see the difference between life and death on the right side and the left side. They're both very similar and look extremely well. Going a little bit deeper and a little bit harder, this patient had multiple injuries to the face. A young patient was in a motor vehicle accident, and you can see on your left side, you can see a very large problem on just below the ear and near the lower jaw, also to the upper lip, the nose, and the lower lip. And the dorsum of the nose was also involved. Very, very difficult injury. This is the patient after she, of course, was in a motor vehicle accident, and that's what caused this terrible injury. But you can see a reconstruction of the upper and lower lip. You can also see what appears to be some work on both the upper and lower, both the lower eyelids on both eyes. So upper lip, a little bit of nose, lower lip, and soft tissue below the eyes, and a little bit of reconstruction around both cheeks. This patient was a result of a motor vehicle accident, which also is one of the things that we have to face more on a regular basis than we'd like to. So anyway, what's the long haul here? What do we have going for us? Is this going to all work very good? I think that we have found out over the years that we can do things pretty good with prosthetic kinds of abutments. We need to be sure that we learn how to do our prosthetic positioning. They have to be parallel. They have to be in the right place. And we have to be sure that there's adequate bone and soft tissue to hold them in position. Once we've established that, then we can move forward with other types of issues like soft tissue interfaces if we need to manage that too. And that's nothing more than corrections of the epithelium and placement of, implants in soft tissue that are immobilized critically. Once that's done, we can usually expect those to heal properly, and we can compare them to both intraoral and extraoral positions, usually without major difficulty. And we'll end up in most of these places with pretty darn good implants that we can put hard and soft tissues in position. Other things of interest here are the osseointegration that needs to take place after we place an implant, and that can be anywhere from 2 to 6 months. It kind of depends on how much bone injury we have, and if the implants are lost during an injury and you're redoing it, that compromises things much more. But our success rates on both of this, at least in the United States, is between 94 to 64%. And that's a pretty wide hole. We're, for the most part, a little bit ahead of the Swedish people and other folks that have been looked at. But radiation after an implant has been placed can cause problems too, so we have to be careful with that. But once we get these implants into position and stabilized, they're pretty much there for the rest of the patient's life, or certainly unless they're not injured again. What about hyperbaric oxygen? There are some advantages to doing hyperbaric oxygen, especially on patients that have significant bone losses, and you're trying to magnify and improve the healing process. We have some recommendations that we make, and that is that we need to make the depth somewhere between 10 and 20, and then we usually can place craniofacial implants, sometimes they're lost, they can be replaced a second time. And if we end up with significant implant loss or infections or evidence of loss of bone healing, then that's probably can only be done one time. It's not going to work on every time anyway. The problem that you have is that they don't integrate properly. They also have a tendency to a reaction of the soft tissue. And of course, there's a high risk of infections associated with anything that's inside the mouth like that, whether you're placing an implant or crowning an implant. You can always have the worry about whether or not the soft tissue is going to be able to manage the reconstruction. However, we do have some things that we can report are pretty successful. And there's a list here on the right side of people that have been very successful with it. But certainly temporal, orbital, and nasomaxillary have a very high success rate. Surprisingly, it's better than the oral cavity because the bone and the blood supply is better. And it seems that the external ones seems to prepare and result better than those that are placed inside the mouth. However, there is some success rate in all areas that can be good or bad. And so I think we have to remind the patient or the patient's family that there's always some risk associated with this kind of reconstruction. Some of the results that we've had over at our university, we had a group of 232 patients that had over 500 implants. They ranged in age from 2 to 76, and the follow-up was from 3 to 96 months. And our average success rate was 65.3%, which isn't bad, considering you're kind of working uphill, so to speak. Of course, at the university where I'm from, we have a lot of other things that we've tested and tried to do with temporal bone uses, placing implants simultaneously, in burn patients, in patients that have Treacher Collins problems, Goldenhar. I'm sure you're familiar with all of those. We also have some orbital issues we have to address in these patients. And, it's never a perfect outcome. What we're doing is the very best we can so that the patients have what I would call enough outcome that they're going to be satisfied in order to feel like they've improved and not stayed the same. So soft tissue reactions is all part of the whole story too. The total soft tissue reaction can be as little as 14%, which is low. They can be higher than that too, and soft tissue reactions can get up into the 50 range if the soft tissue is not compromised from a blood supply standpoint. Orbits are difficult. Temporal areas are also difficult, and you just have to be careful whenever you're doing this. However, our success rate on implants runs around over 90%, stable with minor problems over a multi-month outcome. University of Texas also our experience with total failure rates. Temporal bone is usually very low. Orbital bone is very low, and nasal is also very low. So we're in pretty good shape on our failure rate from that standpoint, and that's proved to be very successful. Here's another patient just showing multiple injuries in the preauricular area on both sides, both patients, top and bottom here you can see, and reconstruction of the area around the ear and reconstruction, as I've already showed you before. Titanium cranial implants are coupled with some custom prosthetic reconstructions, which can also give you a good, excellent alternative for traditional approaches. And I think that it should be used very carefully, and not unless you absolutely have to do it, but if necessary, titanium cranial implants with reconstruction on facial soft tissue can be also improving and significant. I think that covers the majority of different types of utilization on these patients. Gives us a good opportunity to see what's out there. This photograph is an air view of our university, and it's been there for close to 50 years now, and maybe 55, I think is probably about where it is. And you can see the size and the magnitude of all these white buildings are all part of the University of Dallas, Southwestern Medical Center of Dallas, Texas. I'd be happy to discuss some discussion, and I'm going to turn this over to our host, and we can make a decision as where we're going to go from here. Thank you very much for the invitation. I appreciate your confidence, and I'll look forward to
Thank you very much for your kind presentations, and it's very nice case. And so let me check if there are any questions from our participant. Before that, I would like to ask you about, because we have some experience with the ear implant prosthesis. And what I saw from your cases, I saw that some of your cases, you left some part of the ear. You didn't remove all the part of the ear cartilage, right? Or you remove everything before putting the implant?
Yeah, well, the implants, it's hard for me to understand what your question, but when we do it around the ear, the implants are placed in what I call osseous bone. In other words, we're going to take a good radiograph, make sure it's three-dimensional, and we're going to put our implant by choosing an area where the bone is thick enough and strong enough to manage, stability.
Yes.
Does that answer?
And if there's some part of the soft tissue, because it depends on the defect, right? If the defect has some part of the, what this is called, the ear, soft tissue, so do you recommend to remove that first and then, yes?
It has to be done staged. Yeah, definitely has to be done staged.
What do you do first?
I would do the implants first, because if you don't, I think you're going to compromise the soft tissues. And so some people will do it both ways, either way, but my choice is to put the implants in first.
I see. Thank you very much.
Anybody else?
Okay. It's very nice and very good to have you for this honor online webinar today. And if there is any questions, maybe we can do afterward. And at this moment, there is no more questions. So I would like to thank Professor Sinn very much for your kind presentation today.
Well, I would like to thank for the invitation. I hope that you're taking home some new information and give everybody a little more confidence of what they're doing in the treatment of patients in these areas.
Yes, and I hope very much to have you on site in Thailand very soon.
Okay. Thank you very much. I like Thailand.
Okay, thank you very much and see you.
Okay. Thank you. Good night.
Good night. So next time, I would like to introduce you the next time of the 4th online webinar. It will be held in July 25 with the topic of the current management of craniomaxillofacial trauma by Professor Larry Cunningham. He is also a very well-known professor in oral and maxillofacial surgery as well. So please continue join with us the next time in July. See you. Bye-bye for today.